I don't know, once you do the 4 year optometry and you spend a very long time for reading and writing, and then I spend a good amount of money, then we should have some kind of reputation in the profession. So, especially, I think as we made this platform so that we can just promote for the clinical optometry, and these the presentation is just going to be an example what we are planning, what we are thinking about. So, Puneet, I think now we are with the time. We can start now.
Yes, sir. Now we are live on YouTube also.
Excellent, excellent. Just go ahead. Oh,
So, good evening, everyone. I am Optom Puneet, co-founder and CEO of CureSee. I welcome you all in today's session of Learning from the Budding Optometrists, the session one of the series organized by clinical optometry classes. Today, we have to start from Amblyopia Screening in Pediatric patients, a case-based approach. This is our first keynote speaker, Optom Zeba Naz. She has completed her optometry degree from Jamia Hamdard University and is currently serving as the vision therapy consultant at CureSee. It's a pleasure to have you here, Zeba. You can now please continue with your presentation.
Thank you, Puneet, for the introduction. And good evening, everyone. So, today we are going to discuss amblyopia screening in pediatric patients. It is a case based approach where we'll also see how we manage the patient using a vision therapy software that is CureSee. So, firstly, I'd like to acknowledge and thank team of Cure for Eyes and CureSee for giving this opportunity, and also the patient for the media consent. So the patient was a 6-year-old female residing in Gurugram, Haryana. So she first presented to us on 23rd of August 2020, and the chief complaint of the patient was blurring of vision, diplopia that was present since 1 year. So we took the case history, that was general history was normal, family history was also normal. The patient did not had any ocular or head injury. There was no past illness history. The birth history was also within normal limits. There was no surgeries or lasers history, and no history of patching or vision therapy. The nutritional status was also normal. Then we did the refraction, and the unaided visual acuity was found to be 6.9 in the right eye and N6 at 33 centimeter. For the left eye, the visual acuity was 636 and N6 at 33 centimeters in normal room illumination. So the dry objective refraction was found to be minus 0.75 diopter spherical, and in left eye it was minus 3.75 diopter spherical. So we did the cycloplegic refraction, and the readings were minus 0.75 diopter spherical in the right eye, and in the left eye it was minus 4.04 diopter spherical. The subjective refraction was also similar to the dry objective refraction. So the best corrected visual acuity in the right eye was 6.6 for distance and N6 for near. And in the left eye, the best corrected visual acuity was 6.18 and N6 for near. So we did the external examination, and the face was normal, head postures were normal, ocular position was also normal, and the ocular motility was full, free, painless in all direction of gaze in both the eyes. So we did the binocular evaluation where the stereopsis was found to be 500 seconds of arc, and Worth 4 dot test confirmed the presence of diplopia. Cover test was found ortho for both near and distance. We did NPC, the readings were 10, 12 and 12 with RAF ruler. Then we went for slit lamp examination, and the findings were normal as ocular adnexa was flat, conjunctiva was normal, sclera was normal, cornea was clear, and anterior chamber was normal in content and depth. Iris was normal in color and patterns, and pupil was also normal as no RAPD was shown. Then we did the retina evaluation, and retina was also fine as the media was clear, PVD was absent, macula was also normal, and fundus was within the normal limits. So the diagnosis was for the right eye, it was myopia, and because there was no hindrance in the ocular media, so the diagnosis for the left eye was an isometropic amblyopia. Why an isometropic amblyopia? Because there is significant difference in the refractive error of both the eyes. So for management, we advise the patient to use glasses with the latest refraction, as the best corrected visual acuity with the latest refraction was 6.6 in the right eye, and in the left eye it was 6.18. Then we gave active vision therapy, that is CureSee, to the patient, and the review was planned after 1 month. So in the second visit, that was on 27th of September 2020, the aided visual acuity in the right eye was 6.6, and in the left eye it improved to 6.12 from 6.18. So the dry objective findings were minus 0.75 diopter spherical in the right eye and minus 3.75 diopter spherical in the left eye. The cycloplegic refraction was done, and readings were found to be minus 0.75 diopter spherical in the right eye and minus 4 diopter spherical in the left eye. The subjective refraction in the left eye was found to be minus 3.50. So the difference was not much. So the glasses were not changed, although the visual acuity improved, and the active vision therapy was also asked to be continued. We asked the patient to review for after 1 month. Then in the third visit, that was on 24th of October, the aided visual acuity in the right eye was 6.6, and in the left eye, it significantly improved to 6.9. So we did the dry objective refraction, and in the right eye, the reading was minus 0.75 diopter spherical, and in the left eye, the reading was minus 3 diopter spherical. The cycloplegic refraction in the right eye was same, minus 0.75 diopter spherical, and in the left eye it was minus 3.50 diopter spherical. Subjective refraction was also similar to the dry objective refraction, and the best corrected visual acuity in the left eye improved to 6.6 part. So in the first visit, the best corrected visual acuity was 6.18, that has now improved to 6.6 part. So the glasses were changed to the latest prescription, and the active vision therapy is also continued with reduced duration, and the patient has asked for review after 1 month. So we did the binocular evaluation, and the stereopsis also improved to 75 seconds of arc. Worth 4 dot test was within the normal limits. Cover test was ortho for both near and for distance. NPC was found to be 8, 8, and 10 with the RAF ruler, and EOM was full, free, and painless in all the direction of gaze. Talking about the patient's experience, yes, the visual acuity improved significantly. There was no more complaints of diplopia. The stereopsis improved, and also the eye-hand coordination improved. So what does active vision therapy software use? So it uses random dot stereogram as we do the test in for stereopsis. It is nothing but random dots that are spread on a particular surface, and the patient is asked to identify the specific pattern using anaglyphs. So in this, the patient is given these in the form of therapeutic exercises. So the stereo acuity of the patient improves. Next is dichoptic principle. It is nothing but the use of two colors. So here we have used red and blue color that provides wide variety and range of wavelengths. So there is no mixing of two colors by the eyes. Next is anti-suppression therapy here with the dichoptic principle. So each eye is given individual field, and a separate and individual field to each eye. So if the patient sees red stimuli, they'll only see the red stimuli with the red filter, and with the blue stimulus will be seen by the blue filter. Next is crowding phenomena. So in this, the patient has to select a particular stimuli amongst the huge stimuli, variety of stimuli present. So the stimuli that has to be identified among the random stimuli will be present at the top of the screen or the bottom of the screen. Next is individualized contrast threshold. So the patient will be asked for the red and blue calibration threshold that is needs to be set by each patient, and to the point where they can just see the circle starting up to appear wearing anaglyphs. So it's always better late than never. So we should always, as soon as we screen any amblyopic patient, we should start the treatment as soon as possible, because the sooner you start, the efficiency of the treatment will be way better. And everyone should start doing vision therapy, because we have to build our army so that we can add value to that patient's life. Thank you.
Thank you, Zeba, for this wonderful presentation. I'm pretty much sure vision therapy is changing life of many patients worldwide. Now, before getting on to the question answer round, I would like to introduce our panelists. So with us, Professor Monica Chaudhry ma'am has joined with us. She is the director of School of Health Sciences in Sushant University, erstwhile Ansal University, Gurugram. She has been the HOD to me also. I am also one of her students. And it is an immense pleasure to have a panelist who has an experience of nearly 3 decades in the field of optometry. So we welcome you, ma'am. Thanks for joining.
Thank you so much, Puneet, and wonderful presentation which has come in. In fact, the presentation skills were very nice. I just missed the initial part because the moment I reached, I logged in. So what was the age of the patient?
I'm 6 years.
Okay, so that's very good. Did you also try occlusion in this patient?
No, ma'am. For this patient specifically, we did not try occlusion, but a similar case, we had a similar case where the patient was earlier given occlusion, but the improvement was not much for 1.5 years. They did occlusion for 1.5 years, but the improvement was for one line improvement in the Snellen's chart.
Good.
Next on the panelists, we have Optom Suneel Dixit, sir. I guess everybody here knows who the man is. He has impacted many lives of patients because he is indulged in clinical optometry since a long time now. And he is the one who has inspired many of us to get indulged into the clinical field of optometry. Welcome, sir.
Thank you, Puneet. Thank you so much for this lovely introduction. And now I'm just looking for the chat box if we have any question. Otherwise, we can move on our next presentation. Good evening, Monica ma'am. Hello.
Sir, I guess Monica ma'am has lost the connection somehow.
Okay, no problem. So now I think if we can just check the chat box, we have any question?
Not right now, but if anybody has any question, please feel free to ask. We'd be very happy to answer you. And that is the only way we clear our doubts.
So even I would like to ask something, one question to Zeba. As I have seen the many patients, at the age of 30 or maybe below 30 is quite easy to improve the vision with the vision therapy. But I have no experience with the patient of like age 45 or 50 or even 55. So, do you have any patient who like benefited at the age of 50 or maybe 45? And if yes, then you can share your experience.
Yes, sir. With vision therapy, the most busted myth is that amblyopia has no treatment of amblyopia has no age bar. So yes, we have patients at the age of 50 who have we have given the treatment to them, and the progress was I would say not as efficient as the patient with the age of 6, but yes, within 4 months the patient has improved from 624 to 69 within 4 months. So yes, the patient can be treated with of any age can be treated with vision therapy.
Right, thank you. And especially what I have seen in a few patients, suppose the patient has 560 vision, right? I think I lost my internet connection. Am I audible?
You are perfectly fine. Please continue.
Okay, right. So suppose if patient has 560 vision and we have started vision therapy, and once after like 3 months or 5 months, 6 months, whatever we have on a limit of that software for the therapy. So once we suppose complete the course, or like the vision therapy once, and we could achieve only 612 vision. So do you think we should start rescheduling for that particular patient, or is it the extreme line where we should not try again? So that will be the best vision for those particular patient.
No, sir. If the patient is improving to 612, that means there is still scope of improvement. And then we can start the vision therapy. We can continue, ask the patient to continue vision therapy. And we can just keep on looking and reviewing the patient.
I
Right.
would
Thank
also
you.
like to provide an input here. Vision therapy is not something which is standard for everybody. It is customized and individualized for each patient. So we have to tailor it for the expectations and for the needs of the patient, just like how we do it in the low vision segment.
Right. Right. And Puneet is an expert of vision therapy here with us. So I would like to ask one question from Puneet also. Puneet, as we have so many software in the market, so how you describe how the means why the practitioner should go for the CureSee only? Is it has any kind of extra advantage from another one?
Yes, sir, definitely. I'll tell you the first and foremost one, it is the most affordable vision therapy software on the planet. So we are the single ones who provide vision therapy in offline and online both modes. So if the patient is rural also, the patient can get access to vision therapy. He does not necessarily has to have an internet connection. He can perform vision therapy even without an internet connection due to the online and offline mode present. Secondly, we are the most affordable ones, and we customize each and every patient's therapy. We provide option of contrast threshold, options of many newer exercises and newer technologies coming in. So we are more focused on the research and technology segment, which makes us different, that we are dedicated to provide the best to the patient and empower the practitioners. As we are the most affordable ones, all the benefit goes either to the hospital or the optometrist, empowering the community of optometrists all around and the eye care fraternity itself.
Okay. Right. So suppose as an common optometrist, if they wants to go for this CureSee, then how they should connect with you, and what is the right way to connect for this software?
It's a simple three-step procedure, sir. Either if you are a patient or if you are a practitioner, both has to go to www.curesee.com. There they will find an option to register. Once they register, somebody from our team will contact them and get them started. We provide vision therapy training before, so that we ensure that the practitioner is compliant and is efficient in performing vision therapy. Then we provide support from our end to manage their patients also. So that is how one can easily start. Just we have to go to curesee.com and register for the software. Then we can start performing and doing vision therapy for our patients.
Right. Excellent. Excellent. Monica ma'am, are you there? Hello.
Hello.
Uh,
Hello.
I think ma'am lose the connection. Hello, ma'am, you are there?
Yes, I'm here.
Okay, okay, right. So, ma'am, would you like to add anything on this as we are moving on next presentation? So, would you like to just summarize
Yeah, I
the
think
thing?
it was wonderful. But what she should do is, next time they should try to bring in a comparative research paper where vision therapy over occlusion, because occlusion is so far the gold standard. So if he could summarize some of the research papers where vision therapy is proved equivalent or at least better to this case report is nice, but some evidence base is actually also relevant if you have some research papers concluding on it.
Right, right. Thank
Good
you.
effort, very nice.
Okay, so Now we should be moving on to our next speaker for the day, that is Kanchan Gupta. Kanchan, can you please start sharing your screen? Yes, good. So Kanchan has passed out from Uttar Pradesh University of Medical Sciences, SAFI, Etawah, and she is presently an intern at Ahooja Eye and Dental Institute. Kanchan is going to talk about chemical injury, optometric management, and referral. This is something which many optometrists in this generation are lacking. We are not very much aware about how to manage the injury part. So in this is going to be a very interactive session, and let's see what it brings to us. Kanchan, if you can just go to the slideshow in the bottom side.
Yes, sir. Hello,
Yes, you are perfectly audible.
I'm audible.
Yeah.
Okay. Thank you so much, sir, for introduction. Good evening to all of you.
Sorry to interrupt you, Kanchan. I think you have to go for the full of his screen, I think. ये full screen पे आपको जाना है.
Full screen.
You have to just look at the downside. There is an option for like you have to keep your presentation in full of screen. Yes. Go more next, more next. Go more one.
Yes, this one.
Next one, next one. Yeah, this one. Yes.
Okay.
Yes,
Hello.
excellent.
Hello, everyone. Good evening to respected sir and ma'am. Firstly, I would like to thank you so much, Suneel sir, for giving me this opportunity, and it's my pleasure to introduce myself. My name is Kanchan Gupta. I completed Bachelor of Optometry from Uttar Pradesh University of Medical Science (FI), and now I am pursuing internship from Ahooja Eye and Dental Institute, Gurugram. So today, today my topic of my presentation is chemical injury, optometric management, and referral. So let's start from the introduction. Ocular injury is one of the common causes of acquired blindness in children. The consequences of childhood injury are harmful as it leads to permanent blindness and visual handicap. It also affects the physiological, social, and emotional development of a child. Before sharing my case, we should know about what is chemical injury. Injury ranges from direct damage to cells and tissues by caustic agents like as strong acid or bases. Remember, injury is more devastating than that of acid injury. Mild ones will produce conjunctivitis, while more severe ones may cause to turn white. Cornea turns white. There are many different modes of chemical injury. These usually occurs due to external contact with chemicals under following circumstances, like as a domestic accidents, agricultural, chemical laboratory accidents, deliberate chemical attacks. In domestic accidents with ammonia, solvent and detergent and cosmetics, and in agricultural accidents due to fertilizer, insecticides, toxins of vegetables and animal origin, and in chemical laboratory accidents with acids and alkali. Deliberate chemical attacks with the acids to disfigure the face. There are many symptoms like as eye pain, eye redness, blurring vision, watery eye, irritation, inability to keep your eyes open, feeling to foreign object in the eye. There are the signs: swelling of the eyelid, conjunctival hyperemia, irregular corneal surface, cornea may become opaque or edematous. Now I'm going to share my case. So there is a 5-year small girl presented in late evening with complaint of severe pain in left eye, and the right eye was normal. The history of patient is chemical fallen in left eye, that is acetic acid. So as an optometrist, what can we do? On examination, we find lid is normal, cornea have edema or chemosis, and conjunctiva had many congestions, and anterior chamber and iris are normal. So, as an optometrist, what can we do? Firstly, wash the patient's eye with normal saline of 1 to 2 liter of solution for 30 minutes. Firstly, wash the patient eye. There is a small video. Sir, it's not open. And we prescribe antibiotics like as erythromycin ointment 4 times a day, and cyclophagic agents like as atropine, cyclopentolate, artificial tears, lubricating eye drops. Finally, refer to as an ophthalmologist, refer to corneal surgeon as early as possible for further management. Remember to never patch the eye in chemical injury. This is the picture of next day when the patient met with an ophthalmologist. This is the picture of next day. Finally, we got this result after 1 week. This is the picture of after 1 week. And the home message is, as an optometrist, we should aware with the ocular emergency situations. Remember, never patch the patient's eye with chemical injury. Always refer to the corneal surgeon for further management. And optometrist has played a role of bridge between patient and ophthalmologist. Thank you. Hello.
Thank you, Kanchan, for your presentation. This is very, very enlightening for the optometrists who are with us right now.
Thank you, sir.
If anybody has any questions, please feel free to write up in the chat box. We will take up the questions from there.
I think audience should come forward and discuss this.
Yes. Actually, ma'am, what happened with optoms, especially in a clinical practice, one suppose we are in hospital and then if see any suppose in a rural areas and we have any patients of emergency, and suppose patient has not the backup of ophthalmologist, then as an optometrist we cannot say I'm not like authorized to treat this patient, and we just run away from our responsibility. So there is some kind of the way to treat the patient where you cannot cross your boundaries. So within your limit, even there is a possibility you can treat the patient. So what is the best way to treat the patient in an emergency situation? Even, and we are even going to start from the next month. So this is like if you suppose any chemical injury patient visit to any optometrist, so if you just wash the eyes, then almost 80% you just treated the patient. There's nothing has to be done else. If you just wash the patients with the normal saline like BCC, RL, ringer lactate, and just refer the patient to the ophthalmologist, then the patient will 80% get relief from your wash only. But if you don't wash and the patient will wait for next day, then I'm very sure the patient will lose the eyes. The whole cornea will be melted. So as an optometrist we should aware how we can. So this is, if everyone just keep the things how I can help the patient in your mind, then there is are multiple way to treat the patients, and even without crossing your
I
boundaries.
think I would like to add here, Sunil, you are very rightly said. You see, the first aid should be, as we are primary eye care, should be our job. Unfortunately, the law does not permit us to do anything like this in date to day. So this is something which you all should be representing also. You should fight for these things that government should done. I mean, these cases are actual a good thing when you can document and prove that this patient's vision could be saved because the optometrist could give the first aid treatment. If it was not, then the patient would have lost his eyes forever. These are the cases which, if we try to reflect, we can actually fight for our rights of prescription and even at least management at the primary level.
Yes, ma'am. Yes, ma'am. And it was actually wonderful presentation by Kanchan, and she is an intern at Ahooja and Dental Institute. I'm really proud to see the patients how she presented. It was actually wonderful presentation. Thank you, Kanchan, for
Thank you, sir.
sharing your experience. Thank you so much.
Thank you, sir.
Kanchan, now we have a question from somebody in the chat box. That is how to take vision in severe chemical injury patients, because he thinks that vision is mandatory. So how do you plan on taking vision in severe chemical injury patients? When and how? Can you please elaborate?
Hello, am I audible?
Yes, Kanchan, please go on.
In severe case, so we can't give. I think.
Hello.
Hello.
You are right to
Actually,
say.
see,
Yeah, Kanchan
actually,
is right.
what?
We should not worry about vision at this moment.
Yes, yes, yes,
We
yes.
should quickly do the first aid treatment, bandage and whatever, and maybe on follow-ups. And for all optometrists further, once everything heals up, scleral lenses is also a choice of treatment post the scarring and all. In these cases, it's very likely the patient would have had loss of the cells also.
Right.
So
Yes.
Yes, ma'am.
scleral lenses could be given, but vision should not be, you should take in immediate, it may be light or counting finger, but the first reaction should be washing the eye.
Yes,
And
sir.
this, and especially what I had seen in many cases, and the patient comes with like hyperactivity, and the mind level is very higher emotionally. He's like suffering with the severe pain and irritation. So if suppose you are going to take the vision, he may shout on you, so you cannot take the vision. First you have to just
Wash the.
relieve the pain of the patient, and that is the only way to do the wash of the ice. And after doing this wash, and then you can give a lot of lubricant, and simultaneously you can connect with an ophthalmologist, and then you can send this patient to the ophthalmologist next day. So once he'll reach to the ophthalmologist, then they'll start steroid eye drops like FMLT or Lotipred, and the patient get the relief. So and then next day patient, once he reached to the ophthalmologist, then they can do the vision and everything. But at your level you have to just do the wash only and connect with an ophthalmologist.
Thank you, sir. Thank you, ma'am, for explaining this wonderfully. Now, I would request Kanchan to please stop sharing your screen and to our next speaker, Optom S. Vaishnavi, to start sharing her screen now.
Yeah.
And we have a question coming in from Ashit Tripathi that any changes in treatment when injury occurs by acid or by base? So, is there any change in the treatment modality?
See, actually, there is a lot of changes if you look at the injury that depend on the severity of the cases. So, if suppose the patient is coming like with the total burn of the cornea, then there is the totally different guidelines for the treatment. Like the patient may require some kind of amniotic membrane treatment, etc. So, so at your level, I would suggest, even if there is no any abrasion at the cornea, if suppose it's went like LP only at the conjunctiva or palpebral conjunctiva, then I would suggest to go for the wash. If there is any patient with the injury like chemical injury, then you have to go for the wash first, that's it. And the next the treatment, for the any further treatment, you have to send to the ophthalmologist.
Thank you, sir. Thank you again. And now, Optom Ash Vaishnavi, can you please share your screen?
Yeah. So is my screen visible?
Yes, perfectly. It's visible now. Just try
Okay.
to get it on full screen
Yeah.
now. So as recently we saw the World Keratoconus Day coming. Now it is high time we should learn about detecting keratoconus in earlier stages. That is the topic by our next presenter, that is Optom S. Vaishnavi. She's a Bachelor of Optometry student from Sushant University, erstwhile Ansal University, Gurugram, and intern at Ahooja Eye and Dental Institute. We welcome you, Vaishnavi. You can please just go to the full screen mode and start.
Thank you, Puneet sir, for such a wonderful introduction. Um, I'm grateful to you all for making time out of your busy schedules to participate in this session. Today, I'm going to discuss about a topic on how we can detect keratoconus in earlier stages. So let's start with the introduction. What is keratoconus? So actually, it is derived from Greek words kerato, which means cornea, and conus means cone. That is keratoconus. It is non-inflammatory progressive corneal thinning, which leads to protrusion of the cornea. At present, you have to consider it as a non-inflammatory one, but still there are many studies are going on whether is it a inflammatory one, because still we get the substantial evidence and research. Now we should consider it as a non-inflammatory one. Usually it is bilateral but asymmetric. Some patients may present with only one eye and other eye be normal. And sometimes patient may present with advanced keratoconus in one eye and very certain changes in the other eye. There is no gender predilection. Both sexes are equally affected. And it is most common primary ectasia. Among all corneal primary ectasia, keratoconus is the most common one. So this is how the keratoconus looks. And most commonly seen in the second decade of the puberty age. And it can also be seen in pediatric age groups as well as after the age of 30 years. The good thing about keratoconus is it stabilizes by the fourth decade. That is what the current evidences show. So what are the signs of keratoconus? First one is Flesher's ring. It is an iron ring just at the base of the keratoconus cone. Because of accumulation of iron deposits from the tear film onto the cornea, usually seen at the subepithelial level. It can be seen very clearly with cobalt blue filter. And the second one is Vogt striae. It is a vertical fine lines at the posterior stroma at the level of Descemet's membrane. These are usually vertical in line, and when you apply a slight pressure, they tend to disappear. This happens because when there is a protrusion of the cornea, there is a stress lines. So these are the stress lines. I hope my cursor is visible. So these are the stress lines at the Descemet level. One more important sign is oil drop reflex sign. So it is best as appreciated by distant direct ophthalmoscopy and when you dilate the pupil and do a retroillumination. See, this picture show the classical sign of oil droplet reflex. We can see something drop is falling here. And this sign can be also seen in anterior lenticonus and even in posterior lenticonus can also be seen. Case history. A 32-year-old patient visited to us with a complaint of blurring of vision and distorted glasses, with history of allergic conjunctivitis, history of LASIK at the age of 19 year at Hisar, history of eye rubbing since childhood. So from this slide, we should focus on the history of eye rubbing. From now, I'm going to present a case report on how we can detect keratoconus in earlier stages. So for which we have to start with the vision taking. I took her vision. Her vision was 660 in right eye and 360 in left eye at the time of visiting. So clearly her vision indicates that something is there to be diagnosed. So this was her PGP, her previous class prescription, which she was using already. Then we did her auto refraction. While doing, we saw some distorted images. Then we moved on to the retinoscopy. At the time of doing retinoscopy, the movement of reflexes were not clear. So we took her for the dilated retinoscopy, where we found the Caesar reflex. I just want to add on one thing, that the most important clinical examination to detect the keratoconus, I would say, is a good retinoscopy. If you have a good command on retinoscopy, you can diagnose a keratoconus in very, very early stages, appreciating the Caesar reflex. After the, so this is the definition of the Caesar reflex, that light reflex, instead of being evenly distributed, appears to have a dark center, thus creating the Caesar effect. One more thing I want to add on is, many people gets confused in differentiating between the Caesar reflex and the irregular astigmatism reflex. So I would say the only difference is the Caesar reflex gets disappears, but whereas the it does not the Caesar reflex does not disappear, but the irregular astigmatism reflex gets disappear after some time. So after that, after retinoscopy, we did her pentacam. So this was her right eye, where the central thickness is 393 and the K reading was K1 40 and K2 43.30 diopter. This was her left eye reports. The central thickness was 383 and the K reading were the K1 46, K2 is 47. Then we moved on for the management process. So usually the management for the keratoconus patients are soft contact lenses, RGP, and the C3R. So as a patient is 32-year-old, so C3R is of no use, and also she was intolerable for both RGP and soft. So we moved on for the spectacles. While doing acceptance for her spectacles, we asked the patient to rotate the axis by her own and report the point where she found the letter seems to be clear. Aspects to be noted. When to suspect keratoconus. So this is very important for us in day-to-day practice, because the diagnosis of keratoconus depends on suspecting the patient and subjecting them to the investigation. If the patient comes with a history of eye rubbing, especially with the children's, with the history of VKC or allergic conjunctivitis, in your routine examination, if your auto K reading is more than 48, a patient with high irregular astigmatism, and sometimes a patient can come with 6/6 vision in Snellen vision chart, but they'll be complaining of, like, doctor, that my vision is not good. I don't know how to explain about it, but my vision was good earlier, but now I can see. But it is not that good what I was seeing previously. So these type of patients, you have to suspect something is there in the cornea. Whenever patient comes for refractive surgery, telling that my vision is not good with contact lenses and spectacles, you should have a suspicion. And of course, also, if a patient comes with a family history of keratoconus. Yeah. So that was my presentation. Thank you very much, Sunil sir, for giving me such a wonderful opportunity. And also, I would like to thank Professor Monica Chaudhry, ma'am. Thank you, ma'am. Thank you very much for giving us your precious time today. Thank you. If
The
anybody have
pleasure
any,
was ours, Vaishnavi. Yeah, till the questions come in your chat box, I had few comments to your presentation.
okay, yeah, ma'am.
It feels proud to see students presenting in such good form. And of course, we would like to correct. The first thing is this was a post-LASIK ectasia case and not a keratoconus case.
Okay, ma'am.
Keratoconus is a progressive disorder which is non-inflammatory, but I think in your case, if I understand, this was post-LASIK ectasia, right? So we shouldn't say it as keratoconus, but it is post-LASIK ectasia. Secondly, C3R's decision could be yes taken if this was a progression observed and the ectasia was changing, because in post-LASIK cases, sometimes progression continues. Age is not the bar in that cases, right?
Okay, ma'am.
So if there are
Okay, sure.
distortions happening, and of course, a contact lens is the mainstay treatment for these patients. And we should have worked up again. And I would suggest we should look into that, because even if glasses are 6x6, but the quality of vision would never come. So I think wonderful effort.
Thank
And
you,
I
ma'am.
would request others to take up the questions for it.
Yeah. If anybody have any query, please put it on chat box, or you can also unmute yourself and speak up.
Thank you, Vaishnavi, for your insights to the keratoconus topic. We have a
Thank you,
question
Puneet.
coming in, that is, why do we still need to wear contact lenses after C3R is done?
Okay. So basically, C3R is done to stop the progression of the keratoconus. It is not a refractive procedure. It is a procedure of stabilizing the keratoconus. So that's the answer.
Yeah. Hello, Vaishnavi. Good evening. That was a wonderful presentation. I would like to ask you that in your case presentation, why you have not done the C3R?
Okay. In my case, she was 32-year old. So at this stage, the chances of progression is very less. So that is why. I hope you understand.
I would just
Yeah, yeah.
like to
Thank you.
add here something, as she was the patient of actually at the age of 32, and the progression was already checked two
Yeah.
or three times already recently, and the patient was diagnosed for the keratoconus at AEDI, and the patient was finally advised to wear RGP contact lenses, but and especially I just especially would like to mention here, this patient has been seen by Monica ma'am also. Monica ma'am, आपको याद है ये वो patient है Nancy.
Nancy. Yes, ma'am.
So she was actually very allergic with the contact lenses like RGP contact lenses. So she was not able
Intolerant.
to tolerate those RGP lenses. So finally, she turned to soft contact lenses. So she, with the soft contact lens, she was like a 6'9" or 6'9" partial. So she was able to manage, but she was not a happy patient with the soft contact lenses. But she was also not tolerating the RGP contact lenses. But the patient was already 32. At the age of 32, I don't think so there is require any kind of C3R treatment, especially if the progression is not there. The patient, if suppose the patient has habit of rubbing, then even there is a possibility of the progression even post C3R. So every patient is very individual. So we have to assess if what everything about the patient, and then we have to decide whether we have to go for the C3R first or we have to go for the contact lenses. And the thickness of the cornea is also matter to take this decision. Monica ma'am, hello. Hello. Monica ma'am, you are there?
Yeah, I'm sorry I missed the voice. So what was the question? Last one?
Uh, Actually, someone asked why you did not go for the C3R first, and directly you
I
move
understood.
on.
Yeah, that question I listened. So you see, I would say yes, Sunil, you had said we don't, but post LASIK cases actually continue to cave in. The corneas rather continue to cave in. And if it is ectasia, my personal experience says that there are strong chances of progression. So this patient should be followed up. And as Sunil had said, on if on first follow up or second, till we are sure that the progression is not happening, then only. And at Ahooja Hospital, I know it is very conservatively done. But the moment we find that yes, the changes have come in, the C3R has to be done in such cases also. So there is a very strong possibility if it is a slow progression, the patient may have to go for C3R later. So that is why these patients should be followed up regularly.
Right. And even I just thank you so much, ma'am. And even I would just like to add just fine line, and especially when you see the patient with the refraction. So if you see the changes in the refraction, that doesn't mean the keratoconus is progressing. So for the keratoconus progression, you have to go for the pentacam. You have to evaluate the thickness of the cornea, and then only you can decide is there progression or not. Then you can decide the whether patient should go for the C3R or contact lenses.
Yes, sir. Thank you. And now we have a next question from Ashit, that is how rubbing of eye is suspected to keratoconus.
I'm just looking at Monica ma'am first and then I'll answer. So I think there is some problem with connection. I think at Monica ma'am. So I'll start, and I hope the ma'am will join us. So as you Asit asked, how rubbing is of eye is suspected to keratoconus. No, Asit, it is not like that. You just understand the allergic conjunctivitis is a totally different thing, but it can be a strong reason for the keratoconus. So if patient has allergic conjunctivitis, that doesn't mean patient has keratoconus. The keratoconus has different evaluation of the cornea, and you have to go through all those evaluation. And then if there is a thinning in the cornea and the all parameters are coming like that, then you have to go, you can diagnose for the keratoconus. But yes, in a patient of allergic conjunctivitis, you have to assess the patient in a way of keratoconus also, because there is a possibility of keratoconus with the patient if patient has a history of long time allergies.
Yeah. Sorry, my I think mic was not
Yes.
was muted when I was talking. Acha.
Okay.
So rubbing of eyes, as the question is, there is
Yes.
a very strong correlation, and
Yes.
it is actually documented that people who rub their eyes are very likely to get into these ectasia problems. So the first thing, the moment you detect keratoconus, you have to tell the patient stop rubbing the eye. They may use lubricants, and rubbing of eyes is secondary to allergic conjunctivitis.
Right.
So we usually, when we see patients coming lot from these dusty environment and states like Rajasthan and all, there is a big incidence of keratoconus in that area because it's a very dusty environment and people have a lot of allergies. So kids, 9-year-old, 11-year-old, they get keratoconus, and very strong correlation, they have allergic conjunctivitis. Because of allergic conjunctivitis, they are rubbing the eyes, the corneas are thin, and then that leads to progression. So all this is interlinked. However, the etiology of keratoconus is still not confirmed to say yes, this is because of this. Inheritance, genetics, all this is also linked up. But the moment there is chance that you see keratoconus patient, you should immediately tell the patient don't rub the eyes, and allergies have to be treated.
Thank you, ma'am. Next, we have a question from Babita Rajput. She's asking that as an optometrist, How can we decide that we should give soft or RGP lens or refer for C3R? What is the criteria for deciding?
Yeah. So as an optometrist, you should actually, you see, soft lens, the regular soft lenses can only be fit in those cases where the vision is perfect with the spectacle correction. And if the patient is partial vision, you cannot give soft contact lens, number one. And that is only 1% or 2% of patients where you will be able to give. Or it is a very, very early keratoconus, but that too you should think about disposable lenses and lenses with silicon hydrogel and high modulus. Then there are soft contact lenses, especially for keratoconus, which is made by Menicon and Rose Scale soft lenses. The third is next RGP. 90% of your patients will actually benefit with RGP corneal lenses. And whenever corneal lenses fail, we give scleral contact lenses. The next option, if corneal fail. So soft lenses only when the spectacles give a very good vision. Then only soft lenses, the regular soft contact lenses, disposables one that we have. Otherwise, the moment you see ectasia patient, think only about a rigid contact lens. And C3R, the purpose of C3R is controlling progression. It's not a treatment. It will not give, this does not restore vision. C3R only means controlling progression again and again, retarding the progression. So you should actually, if you find a patient with progression, then only you should advise C3R. Otherwise, otherwise, if it is a stable cornea, progression has happened to the worst, no need of C3R. But regular monitoring of keratoconus topographies, anytime you find changes, that's the time when you have to immediately refer to the surgeon for C3R. But even after C3R, patients will have to wear the contact lenses.
Thank you so much, ma'am, for simplifying it for
Thank
all
you,
of
ma'am.
us.
And the second part of the question was like, I just would like to add on this. He asked that what is the average corneal thickness for C3R? So normally, in the average corneal thickness is like 400, but in few cases you can go with the some like the making the corneal thickness swelled, and then even you can go for the procedures. And the second thing is, once you go for the it is a cross linking like collagen fibers, so you just try to making the corneal collagen fibers is stronger. So once the collagen fiber become weak, then it turns to onwards like outward like keratoconus. So the procedure is just for to stabilize the cornea at the same stage. But still after C3R, if the patient has a habit of rubbing, then there is a possibility of progression in keratoconus. And even post C3R, the patient definitely require contact lenses. But yes, there is a possibility after the procedure, there are a lot of changes in the cornea is going to happen. So the fitting will be changed, and even you have to then take the decision as per the parameter, what kind of contact lenses you wants to go.
Yes. So basically, what we do in C3R is that we remove the epithelium and we put the dextron riboflavin. Then the dextron riboflavin swells to the cornea for more than, as Mr. Suneel sir said, 400. So for more than 400, then we apply the UV light. So the main thing is putting UV light because it can damage the endothelium. So we have to be very, very
Yes,
careful
yes. So in
while doing
special
the
cases
C3R.
only,
Yeah.
uh, yes. So especially we can just take in a special, very special situation like 370, 370 micron cornea only. And if it
Yes.
is below that, then you cannot go for the
Cannot do
C3R even.
C3R. Yeah.
Thank you, sir. Now, next we have a question again from Ashit. He's asking, is there any chances to develop keratoconus in post-LASIK patients?
If that question is here, yes, there is a very likely chance. If the patient is not properly selected, it is very likely that the ectasia, we shouldn't use the word keratoconus, we should say ectasia can develop in these patients. And we do come across patients with LASIK after some years who have shown these kind of complications.
Thank you, ma'am. Suneel sir, would you like to add anything to it?
So I think already ma'am explained. So it is exactly it is ectasia. So even if the patient had poor assessment before the LASIK surgery, so in those particular cases, this situation can develop. Yes, of course, and then maybe patient require RGP lenses also to correct the clear vision. So, but it is not a keratoconus. This is a totally different situation. You cannot diagnose the cause and use for the diagnosis is ectasia, as ma'am said.
Yes, sir. If anybody has any other question, please write it now. We are going to wind it up very, very soon. Till then, I would like to comment that it was an excellent presentation skill by Optom S. Vaishnavi.
Thank you.
Thank you, Vaishnavi, for the wonderful presentation. And I would like to invite Monica ma'am to just summarize this event because nobody is here better than you
Oh my God.
to summarize this session. And it is actually honor for us to be to share you as you are sharing your previous time with us. Thank you so much. Thank you so much, ma'am.
No, Sunil, I think the thank you should be from our end. It's a wonderful initiative that you have taken where I have really enjoyed to see the young budding ones teaching each other and bringing in these cases. I would rather say that continue to do these kind of initiatives. It is wonderful that each one is, and that's how we learn. अगर मैं अपनी life में वापस जाऊं 33 years back when we were students and when we learned, I still date say my patients were my teachers. And if you get into that concept, you'll learn a lot because you see, we did not have teachers like what you see across these days. So, who taught us? Patients. And remember, every patient should be taken as a teacher. And if you go by step, why it happened, how it happened, what should be the best thing, I think you don't need teachers then. You learn everything from your patients. So, this initiative, keep it in mind. And I would appreciate, in fact, Suneel is saying precious time. मुझे तो अभी भी वो दिख रहा है कि he is still in work and Puneet सारा दिन ये लोग काम करते हैं. Sunday also they work. I think it's something which you all should learn, the dedication and the hard work that they all do. आप लोगों को इनसे सीखना चाहिए. And congratulations to everybody who presented. It was worth my time. Thank you so much. Thank you.
Thank you, ma'am.
Thank you so much to all the presenters, our esteemed panelists, and the guests for the evening. Also, in the chat box, I saw a comment from Gagan sir. He's saying, wonderful session. Many congrats to each and everyone. Keep it up
Thank you,
to all the
sir. Even
participants.
Gagan, sir, thank you so much for being with us here in the platform. It's like honor for us. Thank you so much, Gagan, sir. Thank you.
So thank you everyone. Have a
Acha, I didn't know Gagan ji is also in this session. Oh, I think वो भी एक मेरे टीचर ही हैं. वैसे उनको पता नहीं है. उन्होंने भी मुझे बहुत कुछ सिखाया है.
Gagan, sir, you are there? Puneet, can you just unmute Gagan, sir, for some time?
yes, sir. He's on.
Okay. Hello.
मैं इनफैक्ट आई वुड से आज से 10-12 साल पहले की बात है. गगन जी ब्रॉट इन स्क्लेरल लेंसेज इन इंडिया, और जो एक आने वाला टाइम है वो मेक इन इंडिया. अगर उसका किसी को ऑप्टोमेट्री में अवार्ड देना है तो सानीज को दिया जाना चाहिए. फॉर आज की डेट में कोई ऐसी चीज नहीं है जो ये कॉन्टैक्ट लेंस में अब नहीं बना सकते हैं. अनफॉर्चुनेटली यस, हम लोग अभी उस मल्टीनेशनल वर्ल्ड में रहते हैं और हम क्वालिटीज को कंपेयर करते हैं. बट आई थिंक अगर हम मेक इन इंडिया के ओथ पे सब चलने लगे हैं तो एक टाइम आएगा जब हमें बाहर से कुछ भी नहीं मंगाना पड़ेगा और सब कुछ यहीं मिलेगा. एंड ही इज अ पर्सन जिनका मैंने पैशन देखा है. और जो मतलब लेंस जब इन्होंने शुरू किया था बनाना, खुद आना, पेशेंट में देखना, फिर साथ बैठना, हम दोनों बैठे हैं, फिर उसके रिजल्ट्स अंडरस्टैंड करना, फिर मॉडिफाई करना, फिर क्रिएट करना. सो आई थिंक इतनी अच्छी लेबोरेटरी सपोर्ट के होने की वजह से ही हम प्रैक्टिशनर्स जो हैं परफॉर्म अच्छा कर सकते हैं. एंड आई थिंक ही नीड्स
एंड स्पेशली मैम, मैं तो मैम के साथ ही मैंने काम सीखा है, मैम से ही सीखा है सारा कुछ. और हमने जब स्टार्ट किया था मैम, 8-10 साल हो गया यहाँ पे आरजीपी प्रैक्टिस पे. तो मैंने मुझे लगता है मैंने जब भी गगन सर को कॉल किया होगा कि मुझे ये स्पेशली ये चाहिए या इस तरह का चाहिए, मैंने कभी भी उनसे ना वर्ड नहीं सुना. आई हैव नेवर हर्ड no words from Gagan sir. He always encouraging for any kind of help, to not to the optometrist who's like in a public domain और या कुछ भी ऐसा नहीं है. मतलब एक छोटा सा भी कोई दूर बैठ के फोन करता है, then he respond very well and he always encourage उनको सपोर्ट करना, हर तरह का सपोर्ट करना, पीछे से कोई प्रॉब्लम होती है उसके लिए लेंस प्रोवाइड कराना. सो आई थिंक जो एक्सपीरियंस हमारा सिल्वर लाइन गगन सर के साथ रहा है, दैट वाज एक्सीलेंट है. और अभी होप के वो ऐसा ही बढ़िया सा चलता रहेगा. थैंक यू गगन सर. और हम ट्राई कर रहे हैं कि आप, अच्छा सर का मैसेज आए कि सॉरी आई कुडंट अनम्यूट माई सेल्फ. Puneet, you can you just do the help?
Sir, there is some condition at sir's end, so he cannot unmute right now.
Right. So, Monica ma'am, would you like to add anything as in the last comments from your side?
No, I think we appreciate all this, and everybody's contribution was exemplary. So let's continue to do this good initiative.
Thank you, ma'am. Thank you, ma'am. Thank you, Puneet. Thank you again, Vaishnavi, Kanchan, and Zeba for the wonderful presentation. And next Monday, again, we have the same webinar, which is again case-based. It will be again case-based presentation. So, Puneet, would you like to add the last comments from your side?
Sir, I'm actually really very much surprised by seeing the presentation skills of these students. When I was a student, I was not this much eager to come in front of audience, always hiding somewhere in the back seat. So this is really a very, very big step and a step forward in your professional career. So I wish you all very, very best of luck and a good night to each and everyone. I guess we all
Thank you. Yes. Thank you, Puneet, for moderating wonderfully the session. Thank you so much. Thank you all the audience who's like sharing your time with us. Thank you each and everyone. Thank you so much. Bye. Good night. Thank you, Gagan sir, for being with us. Thank you so much.
Good night, everybody. Good night. Good night.